I want to remind you that on Monday, the 22nd, we will be going over glomerulonephritis, cancer of the colon and the prostate, and kidney stones. So we have a lot of information to go over that day. A couple of things that I wanted to review with you related to what we talked about the other day. The lab values that we talked about, the AST and the LDH are associated with the liver. And if there's any type of a problem involving the liver with the gallbladder, it may be elevated. Typically, your AST is 0 to 35, and your LDH is anywhere from 100 to 190. And I'll just use those references from your book. But like I told you the other day, just be mindful when you're in a facility, the reference range may vary just a little bit. So just make sure you know what they are. And typically, whenever you go into the computer and pull up that lab value, their reference range usually pops up. So you won't have to look too far to find it. And then the other two values that we talked about was the amylase and the lipase, and they are associated with the pancreas. So if there's anything going on, any type of inflammation, infection, anything like that that's going on with the pancreas, those levels may be elevated. Typically, your amylase is going to be anywhere from 30 to around 220. And your lipase is anywhere from 0 to around 160. We also talked about the bilirubin. We talked about the conjugated bilirubin, which is your direct bilirubin. And typically, you're going to see it elevated whenever there's some type of a biliary obstruction. Maybe there's a stone in the bile duct or something related to that. And your levels is 0.1 to 0.3 normally. And then your conjugated is more of your indirect bilirubin level, but you can also see it elevated whenever you have any type of an obstruction in the biliary tract as well. And your values for that particular lab test are 0.2 to 0.8. And then we talked a little bit, I think, about the total bilirubin. This is the level that you're going to see elevated if there's any type of a biliary obstruction or any type of damage that has occurred within the hepatic tree. And the level is 0.3 to 1.0. Okay? White count. You know what your normal white count is, right? We talked a little bit about that. Do you remember what your regular normal white count is?
5,000 to 10,000.
Okay, all right, yeah. And those are the main lab values that we talked about. And of course, your electrolytes, but you know what your normal electrolytes are, so I'm not worried about that. So, okay. I am going to put the recorder on now. So just wanted to make you aware of that. And so I'm going to share my screen with you, and then we're going to move on to peptic ulcer disease today.
I have a quick question about chronic cholecystitis or whatever, gallbladder disease. So when you were talking about it, you said that there's usually no stones involved. But when I was reading the book, it said that there usually were stones involved for chronic. But there were two types of acute, where one of the types was with stones and one was without stones. So I just wanted some clarification on that.
Okay, go with what your book says, because that's what your reference point is. But I will tell you that in the real world, typically whenever you have the chronic, a lot of those patients do not have stones, or we never even know they have them until the time of autopsy.
Okay, gotcha.
Okay. Okay. So let's go ahead and get started with our peptic ulcer disease PowerPoint. I'm not going to read the objectives to you. You have those in front of you, so there's really no point in me reading those. Let's move on to the definition of what a peptic ulcer is. There's basically three kinds of ulcers, and we'll talk more about those in just a couple of minutes. But basically what an ulcer is a circumscribed ulceration somewhere in the gastric mucosa. And it can occur in areas that are exposed to high concentration of hydrochloric acid, which is in your GI system, and pepsin. Another cause, very common cause, is the H. pylori infection too, and we'll talk more about that in a few minutes. Okay, the first ulcer that we want to talk about is the gastric ulcer. Typically, this is the type of ulcer that you're going to have with the H. pylori infection. It usually occurs in the antrum of the stomach, and it can also occur around the pyloric sphincter, causing dysfunction there. And basically what happens is that bile will back up into the stomach. And this in turn, you know, bile is very acidic, and it breaks down the mucosal barrier in the stomach. And then inflammation, of course, occurs, and it destroys the gastric mucosa. It causes delayed emptying. Do you know what another word for delayed emptying is? Have any idea? Yes? No?
No.
What was the question? Did you ask a question?
I did.
I'm sorry. Could you repeat it? I apologize.
I did. I said, do you know what the medical term for delayed emptying of the gastric system?
Is it gastroparesis?
Gastroparesis. And you will see gastroparesis a lot with diabetic patients too. It's not uncommon in those particular patients. And with this particular type of ulcer, pain is usually in the upper epigastrum, and it's usually aggravated by food. But I will tell you that those symptoms kind of wax and wane depending on the patient. Some patients do have pain there, some don't. So don't bank on their pain being in the epigastric area. It typically occurs in the late middle age, which is greater than 50. The ratio is 1-to-1. Just as many males develop this type of ulcer as females. There's no differentiation between the blood groups. So type A may be as prone to have it as type AB. So that doesn't have anything to do with it as far as the research that they've done so far. Use of NSAIDs. And we all know that that's a common problem for gastric ulcers too. 10 to 20% of these patients are also going to have a duodenal ulcer. These ulcers usually heal with appropriate therapy and with the proper lifestyle changes. Now, if the patient doesn't comply, once they get to feeling better, they can certainly have a recurrence of these ulcers. Okay, now let's talk a little bit about the duodenal ulcer. This particular ulcer is in the upper portion of the duodenum. It is usually very sharply demarcated lesion in that upper area, and it penetrates through the mucosa as well as the submucosa into the muscle layer. And the floor of the ulcer, or the base of it, actually consists of a necrotic area. So it's going to look kind of dark and discolored like necrotic tissue does. High gastric acid secretions, which makes your pH lower, causes a rapid emptying of the food from the stomach. And then because there's this rapid emptying, there's a decreased ability to buffer the food, and a large amount of acid bolus actually goes into the duodenum. Pain usually occurs, it may be worse with food. It can occur anywhere from 90 to 3 minutes after eating. And this particular type of ulcer also often awakens the patient at night. And this is one of the ulcers that you see the H. pylori infection with. Patients who have these duodenal ulcers are 4 times more likely to have a gastric ulcer, and it too is common in the middle-aged years, greater than 50. Ratios 1-to-1. There is also a genetic link with this particular type of ulcer, as there was no genetic link according to the gastric ulcer research. Patients with type O blood type are more common to develop duodenal ulcers. Smoking can make it worse. And then too, this ulcer as well heals with appropriate therapy, and as long as the patient is compliant and uses the protocol that they've been given. But a lot of times these patients start feeling better, so they stop taking their medicine, and then they end up right back where they started.
Miss Bowie.
Yes.
You said 90 to, like, what time does the pain start after eating? 90 to what?
Typically, it's anywhere from 90 minutes to 3 hours.
Okay, thank you. I just didn't hear what you were saying.
Right. And it may or may not be worse at bedtime. Sometimes this particular type of ulcer pain will awaken the patient at night. But some of the symptoms vary with the individual. So these are just, very generalized symptoms. Now, stress ulcers is something that we see very common after any type of trauma or any type of medical crisis. Basically, the hydrochloric acid level is very high in the stomach. Well, that eats away at the lining, and it begins as an area of ischemia. So what is an area of ischemia?
The area that has decreased blood flow.
Right. So the common manifestation for this particular type of ulcer is bleeding. And we can avoid these stress ulcers a lot of times. And, now everybody that comes into the hospital automatically gets put on a proton pump inhibitor. And that's why, because we want to minimize the chance of them developing stress ulcers. If they do develop a stress ulcer, it can certainly lengthen their hospital stay, and it can increase their mortality, because if they end up having to have blood transfusions and complications from that, it can just make their clinical picture much more difficult to manage, and it makes their recovery a lot slower. Now, one thing that I did want to mention to you, particularly with the gastric ulcers, well, it can happen anywhere, but the gastric, where the stomach sits. Well, right behind it is the aorta, right? It runs along the back side. So if you have an ulcer that eats through the wall of the stomach, it can very easily erode into a major vessel and cause the patient to bleed out very quickly. And that does occasionally happen. So that's why we really, really stress the importance of them remaining compliant with their lifestyle changes and making sure that they take their medication as they are directed to do so. So let's talk a little bit about the etiology of peptic ulcer disease. Most often, it is a result of the bacterial infection. Other contributing factors can be NSAIDs. Maybe they're taking NSAIDs on an empty stomach. Maybe they've been taking NSAIDs for a long time. Maybe they are smokers. Maybe they ingest alcohol. maybe they are on steroids, because steroids can be a culprit for developing peptic ulcers as well. And of course, we all know that stress may also be related to developing stress ulcers or ulcers in general in some people. Some of the protective mechanisms that our body actually has in place is the mucus that we have in our GI system that helps coat the mucosal lining. We have the bicarbonate that helps as a buffer to keep the pH in the stomach from getting too high. We have a good blood flow to the stomach. And then, of course, we have the presence of our prostaglandins. Some of the other medications that may contribute to the development of peptic ulcer disease includes the corticosteroids, of course. Theophylline. I don't know that you all are real familiar with theophylline, but it is an old medication that we used to use for chronic lung disease. It was a pill, but it could also be given in a drip if they were in an acute crisis. But we have so many other newer medications now that I rarely ever see anybody that is on it. Most of them have switched over to something newer and more effective. And the ones that are on it have been on it for years and years and years, and they've done well with it, and they have no desire to change. So that's when you're going to see these patients continue to be on it. It's a bronchodilator. And then, of course, caffeine. We all know that caffeine can be a major culprit of stimulating the hydrochloric acid. And then the hydrochloric acid also is going to delay the healing, because if you've got all that acid in there constantly eating away at the stomach, then it's not going to have a chance to heal. And radiation therapy is also another cause of peptic ulcer disease, because while we have advanced in technology and we can be so much more direct with the radiation beams, it still damages good tissue as well as bad tissue. So you may have development of peptic ulcers if the person has had to have some type of radiation therapy to that area. Maybe it's the esophagus, maybe it's the lungs, but it's in that area. Now let's talk a little bit about some of the complications. And these are things that we want to rule out for sure on patients. We don't want to miss anything. We're first of all looking for any perforations. What might be some signs and symptoms of a perforation?
Abdominal distension.
Okay. Abdominal distension. These patients are going to hurt. They're going to be very, very uncomfortable, because what's happened is there's a hole that has developed in there, and all of the gastric content is leaking out into their abdomen.
Dark or bloody stools?
It could be, if depending on where they're bleeding. If they're the higher up they're bleeding, the darker the blood is going to be once they evacuate it rectally. Bowel obstructions may occur too from the development of ulcers. And I showed you this picture because I wanted you to just see how massive a colon can become distended as a result of an intestinal obstruction. You see how big that is? That looks just extremely uncomfortable. And if you look kind of in the middle part there, it looks like it's twisted off, doesn't it?
Yes.
So there's no wonder these patients hurt. Pyloric stenosis is another problem that occur with these patients. And we'll talk a little bit more about that in our next PowerPoint. But pyloric stenosis is a condition where you have the pyloric outlet at the bottom of the stomach. Well, what happens there is that that area becomes stenosed, which means it becomes much smaller. So food can't pass through like it should. So they may have nausea, they may have vomiting related to this pyloric stenosis. They may also have obstructions that's caused by scarring in this area or swelling. Inflammation can also be occurring in this area at the gastric outlet. Bleeding, we've already talked a little bit about bleeding. What are some assessments that you, or part of your assessment that you would want to look at related to bleeding? How would you assess your patient for signs of bleeding?
Vital signs.
Okay.
Bleeding. You could look at lab work.
Okay. What specifically would I want to look at lab work?
The H&H.
Okay.
What else?
What about the BUN?
Yeah.
Yeah. The BUN is going to be elevated if they have blood in their gut.
Got you.
Okay. And it will also be elevated if they are dehydrated from the bleeding. Now, the bleeding can be a very slow bleed, and they may come in with a hemoglobin of 5, but they're alert, oriented, and talking and are having no problems at all. And it's because it's been such a slow bleed. Whereas if it were in you and I, and we had a sudden drop in our hemoglobin to 5, we would not tolerate it very well. Our blood pressure would go down, our heart rate would go up. Our cardiac output would go up initially in order to try to compensate for it. But sometimes these patients do come in like that. So that's not uncommon either. Gastric cancer may also be a problem with these peptic ulcers. The person may have developed gastric cancer, and it could be related to the treatment that they're getting. It could be related to the disease process itself, but there could be complications of peptic ulcer disease. One other condition that I also wanted to make sure I mentioned to you is it's called toxic megacolon. And it looks very similar to this bowel distension, that the picture that I put over here for you, but it's much larger. And it's just where the bowel becomes extremely dilated. It's huge in a section. And of course it doesn't function because it is so distended and there's no peristalsis there. And these patients are usually pretty sick too. So they may have other complications complicating their picture too. If you have an obstruction, what type of signs and symptoms do you think you're going to see in your patient?
Absence of bowel sounds in certain areas.
Okay.
Nausea and vomiting.
Okay. They may have bloating. Yes. Okay. They could potentially have constipation too. Mm-hmm.
And guarding, like actually guarding the abdomen.
Uh-huh. Now, if you were assessing a patient for an obstruction, would you expect them to be acidotic, metabolically acidotic, or alkalotic?
Acidotic.
I'm sorry?
Would they be acidotic?
They would actually be alkalotic because of the large amount of acid that's in the gastric juices, and their potassium is going to be lower. Okay. So now let's talk a little bit about assessing our patient. How are we going to assess our patient? What are some things we're going to ask our patients?
To rate their pain, tell us where their pain is at.
Okay.
Patient, the number. We can ask them if they've seen any changes in their bowel movements, any blood in their stool. right? Am I close?
Yeah, you're right. You're headed in the right direction.
All right.
And you want to ask them how long have they had the pain? Has it been 2 weeks or has it been 2 years? And you'll have people show up in the emergency room at 2:00 on a Saturday morning with pain that they've had for 6 months. But then you want to know, well, what prompted you to seek treatment now? You know, what changed about it? They may have nausea and vomiting. Food may or may not affect the ulcer. It just depends on the person. Some people will report a burning sensation, while others say that they feel like there is a gnawing sensation in their stomach. They may complain of some chest discomfort. So if they're complaining of chest discomfort, we also need to make sure that we exclude any possibility of any type of cardiac problems too, because the stomach is right there in that area as well. So we want to make sure that we seek a cardiac workup as well so that we don't miss anything. Now, these patients that have these ulcers can really bleed sometimes, particularly with the gastric ulcers. They can vomit lots and lots of blood, and it usually has huge clots in it. And you'll wonder, where is it all coming from? I mean, it's so massive sometimes. And the same thing is true with esophageal varices. I don't know if you've studied about that yet or not, but it's kind of like a varicose vein in the esophagus, and is typically seen with alcoholics or people who have cirrhosis of the liver, because that there's a hypertension in the portal vein, and that causes a backup of blood flow, which dilates those vessels in the esophagus. So those patients can bleed profusely too. It's kind of scary because most of the time they are very awake and alert up until very near the end. And so it's very scary for them as well. And they, of course, they may have blood in their stool. We've already talked a little bit about that. So let's talk about some differential diagnoses. These are some things that we want to rule out. We want to definitely rule out any type of neoplasms or any type of cancerous lesions, which that can be done with an endoscopy. And we'll talk a little bit more about that in a couple of minutes. Pancreatitis, we want to rule that out. We want to rule out any type of pancreatic cancer because it's going to make a difference in the way the patient is treated. They may have diverticulitis that is causing pain in that area. What might potentially happen as a result of diverticulitis? Do you remember what diverticulitis is?
Their intestine can perforate.
Mm-hmm. Yes, it's an inflammation in the intestine. They typically have to have diverticulosis before they can have diverticulitis. And then it's just kind of like it follows a pattern. So they can have perforations, and then you're going to have peritonitis, which is a very, very bad infection in the abdomen. It can be very difficult to treat. Dyspepsia is another diagnosis that we want to make sure that we rule out. Any type of gastritis. Maybe they just have stomach irritation from maybe the foods that they've eaten, or maybe they've taken some medication on an empty stomach and it's just caused a flare-up of inflammation within the gastric mucosa. GERD, and of course MI, we've already talked a little bit about that as well. We want to make sure we work them up good for that and we don't miss anything. So we want to do our troponins, we want to do our EKGs and do a very in-depth assessment on their pain, when it starts, when it stops, anything that makes it worse, anything that makes it better. So let's talk a little bit now about some of the diagnostic tests that we can do. stool for occult blood, but that doesn't necessarily mean that the blood is coming from an ulcer. It can be coming from something else. It just means that they've got blood in their stool and we need to figure out where it's coming from because we don't know. We want to look at our lab values. We want to look at the CBC, hemoglobin, hematocrit, look at your white count to see if it's elevated. We also want to look at our liver function test to make sure that there's nothing going on with the liver and that the liver isn't involved. Amylase and lipase, pancreas, we want to look at that as well to make sure there's no involvement with either of those organs. Typically, the H. pylori is going to be diagnosed if they do an endoscopy. They can do biopsies, and then they will rule out the H. pylori. But there are some other tests that can be used to rule it out now, but they're not used very often. Typically, they still stick to the upper GI because that's the preferred test, since we can get the biopsies and rule out malignancies or the H. pylori. We can also do abdominal x-rays. That's not going to show us a lot as far as the ulcer itself. It will show us if there's a perforation, because if we see free air on an abdominal x-ray, that is not good. We do not want to see free air on an abdominal x-ray. Esophagogastroduodenoscopy may also be a test that may be done. And then we can also do a nuclear med scan for bleeding. And basically what this is that they call it a red tag study. And what they do is they inject this person with like a radioisotope, and then they follow it on x-ray, and it will go to the source of the bleeding, so it helps them pinpoint it. Now, some physicians will repeat it in 1 to 2 days to see if whatever the treatment they chose to implement was successful. However, a lot of them don't repeat it. They just go on the patient's signs and symptoms. Are they getting better? Are we improving? An upper GI barium swallow is another one that can be done. We don't do that often anymore, and you can't do it if you suspect a perforation, because where's that barium going to go? If you've got a perforation, it's going to leak out into the abdomen, right?
Yes.
And then you've got a big problem with a superimposed infection. So in light of that, you probably want to look at your x-rays and make sure that you don't show any signs of perforation before moving forward with anything like that. Gastric analysis is also something that can be done during an endoscopy, and there's a syndrome. It's called Zollinger and Ellison syndrome, and that's just where for some reason there's too much production of acid, and we don't really know what causes that. It's very rare, but it can cause big problem with ulcerations, and they can have tumors with this particular condition as well. Duodenal and pancreatic tumors are about 2/3 more likely to be malignant with this particular type of syndrome being present. But is pretty rare. Everybody doing okay? Do you need a break?
I think we're okay.
Okay, we'll move on then. Okay, let's talk about medications a little bit. Well, of course, our first line medications now are the proton pump inhibitors. I used to work with a girl in ICU, and she absolutely loved GI bleeders. We all have our favorites. And so she loved GI bleeders, and she always said that once the proton pump inhibitors came along, that really put a damper on her caring for the GI bleeders. So they have definitely made an impact. And a lot of the, what a lot of the examples of those are is like the Prilosec, the Prevacid, the Protonix, Nexium. And most of these can also be available in delayed release if needed, or if we can't do that, we can actually dissolve it. If the person has a feeding tube, we can dissolve it and put it down the feeding tube. And sometimes they can have a liquid, or they can compound a liquid for you so that it is absorbed correctly. And basically, the action of this particular type of medication reduces the production of acid by blocking the enzymes in the wall of the stomach that produce the extra acid. And as we know, acid is necessary for most ulcer formation. So if we can block some of that, then that's going to be helpful in preventing some of these problems. Now, some of the side effects that we want to be aware of with these particular type of medications, the proton pump inhibitors, some of the side effects are going to be headache, diarrhea, nausea, constipation, which is, I think those are all true with every medication that you look at, abdominal pain. The person may complain of increased gas in their abdomen. They may develop a rash. And if they are on Lanoxin, which is an old cardiac drug, but you do still occasionally see patients on it, and it's used to control atrial fib, there can be an increased absorption of this medication with proton pump inhibitors. So we need to be mindful of that. And Plavix can also be less effective when a patient is on a proton pump inhibitor. So that's something that we need to educate our patients on as well. We don't want to scare them to death, but we do want them to know that, the Plavix may not be quite as effective, because typically if they're on Plavix, they've had some type of a vascular intervention and they need to be on it to prevent clots from forming around the stents or whatever procedure they had done. Now, if the proton pump inhibitors are used over an extended period of time, and that's years, it can cause osteoporosis because there is a decrease in the absorption of B12. And patients can also be at a little bit higher risk for developing C. diff if they're on proton pump inhibitors, but you typically don't see that without some other type of complicating factors. Now, the next group that we'll talk about is the H2 receptor antagonist. And basically, this group blocks the histamine, which helps to stimulate the gastric secretions. And the most common that you're going to see in this is probably the Pepcid, but even now we tend to use the proton pump inhibitors rather than the antagonists. These antagonists were out many years before the proton pump inhibitors were. So it kind of helps block the secretion of the antihistamine, and typically a treatment is going to be anywhere from 8 to 12 weeks. It just depends on the patient and how well they respond. And a proton pump inhibitor may also be added if they don't improve over time. Signs and symptoms, side effects are very similar to these. I'm not going to go over all of those again, but they're very, very similar to it. And typically this particular group of medications is usually given once a day at bedtime. It just depends on the patient's response to it. Typically, they will recheck them in about 4 to 6 weeks to see how they're doing. If they're doing well, they may continue to leave them on it for anywhere from 4 to 8 more weeks, and then try to get them off of it. And then there are patients, you will meet patients that are on it all the time. They're on it and have been for years and years. Antacids is our next category. Typically, you want to take this 2 hours after a meal, and it's usually effective anywhere from 30 minutes to 3 hours after taking. And the purpose of the antacid is to buffer the gastric acid and prevent the formation of pepsin. Now, we have to use it very cautiously in patients with renal failure because it can increase the absorption of some of their other medications. This medication is typically not used alone. It's like your Tums, your Mylanta, Maalox, things like that. It usually needs to be combined with something else because this just kind of serves as a little coating and a buffer. It's not really getting down to the problem and fixing what the problem is. Liquid suspensions is the most therapeutic form, but some patients don't like the way they taste, so they would rather take the Tums. And of course, the tablets are most convenient. We see the Mylanta and Maalox used as well with this particular type of medication or with this particular type of condition. You have to be very careful with the Tums because you can actually have a rebound acid secretion. So we really don't want to use the Tums to inhibit the secretion of the acid, because what's going to happen is that they're going to take it, and then they're going to end up having a rebound effect. One thing that I do want to remind you about with the antacids is if you have a patient that has congestive heart failure, you want to try to stay away from the Mylantas and the Maaloxes and all of that because they have a lot of sodium in them. Riopan is typically the medication that we use for patients who have a history of heart failure or who are in heart failure all the time, because that particular antacid does not have nearly as much sodium in it as the others do.
Dr. Boone, what did you say it's called?
Riopan, Riopan, and it's an old drug too, old. But that's the one you're going to see used with your little old cardiac patients.
Now let's question. Oh, yes. Sorry.
No.
So for testing purposes, what all should we know about these medications, like the mechanism of action, or just that those types of medications are used for peptic ulcer treatment?
I concentrate more on those medications being used for the treatment and time intervals. When are they given? Because that's something that you really need to know as a nurse.
Okay, all right. I just wasn't sure because I didn't see the information on the PowerPoint. I wasn't sure if it was just like an FYI thing or a need to know.
Yeah. No, you do need to be familiar with the medications because you're going to see these medications as long as you're in nursing.
Okay, awesome. Thank you.
But and know when they're going to be most effective, because that's going to make a difference when you're out practicing, when you're going to give your patient these medications, because, you don't want to give it to them, like 5 minutes before they eat.
Do we need to know med names or just the class?
Just focus on the classes.
Okay, thank you.
Mm-hmm. Okay, now let's move on to the gastric or the mucosal barrier fortifiers. Now, this is one that is like Carafate or Sucralfate. Typically, it's given an hour before meals and at bedtime. And it's kind of like a mucosal barrier protector, and it prevents the action of the acid and the pepsid from breaking down the mucosal wall. Now, it does not inhibit the secretion. It just kind of protects the mucosal wall, but it does bind with the bile acids and pepsins.
So is it like a coating? It's just like kind of coats the stomach, right?
It is. You're absolutely right. And whenever you're giving this medication, you don't want to give it within 1 hour of an antacid.
Okay.
Now, let me tell you another little secret about this one, and just trust me on this because I found out the hard way. You cannot crush this pill. It looks just like any other pill, but you cannot crush it. Now, you can dissolve it in water.
I've done that for patients. She just wanted it to sit in that water, and it literally dissolves like Alka-Seltzer. You see it just breaking down. But they come in a liquid too. They come in that Carafate liquid suspension.
Right. But if you try to crush it, it won't dissolve, because I've tried it before. It didn't dissolve. So don't even waste your time doing that. Constipation is probably one of the main side effects that these patients complain about with this particular type of medication. And it is important to give it like an hour before the meal, because we are wanting to protect that gastric mucosa. And then we want to protect it at bedtime too, because they're not going to be eating anything for several hours. Another one that I wanted to mention to you is Pepto-Bismol. It's bismuth subsolate. And it is very helpful when H. pylori is present, because it inhibits the bonding of this bacteria to the mucosal lining, and it stimulates the mucosal protection agents. Now, one thing we do want to remember with this particular medication is that if we don't want to take aspirin with it, because it has aspirin in it. So if they're taking 325 milligram of aspirin a day, and then they're taking Pepto-Bismol 3 or 4 or 5 times a day, then they're probably getting an overdose of the aspirin. So we want to be mindful about that when we're educating our patients. Now, their stools may be dark, but that's okay. That will pass, and it's harmless. It's not a problem at all. It will pass. Okay. All right. So let's talk a little bit about the H. pylori, because you will see that some in the clinical setting. Basically, this particular type of inflammatory response or infection results from the neutrophils and other chemicals that are activated within the GI system, and then this causes a necrosis of the epithelial cell, which is the lining cells. And then there's a bacteria that is produced, which is the H. pylori, that damages this mucosa. And then what happens is the bacteria kind of burrows up into the tissue, and it may be undetected by our body's immune system, because the bacteria kind of hides out in all of those folds in there. Your typical treatment for H. pylori is going to be triple. We're going to usually have a proton pump inhibitor and 2 antibiotics. It may be amoxicillin or clarithromycin. Flagyl is usually used if they're allergic to amoxicillin. And sometimes patients will tell you that they don't feel real well when they're taking Flagyl. It just makes them feel really tired and just yucky. One of the biggest things that you can stress with this particular infection is compliance, because what happens is they start feeling better, so they stop taking their medication, and they've not completed their regimen, and the H. pylori comes back because we never really got rid of it in the beginning because they didn't finish their therapy. So that's really important that we teach them how important it is for them to finish up every bit of the medication. Now, if it's not H. pylori, then we're probably going to use the proton pump inhibitor or the H2 receptor antagonist to help us with the healing process. And like I said, it can take anywhere from 4 to 12 weeks. It just depends on the response of the patient and how well they're doing and how compliant they are too. And I use compliance gingerly because there's a lot of reasons people can be non-compliant. It's not necessarily related to I don't want to do it. It can be related to not having funds or not having someone to go to the drugstore to pick it up, their medication up for them. They may not live in an area that it can be delivered. There's just a number of barriers that can play a factor in compliance with patients. So just keep that in the back of your mind when you run across some of these that appear to be non-compliant. So we've already talked a little bit about the other medications and why we would use those. So we're not going to spend any more time on that. What type of lifestyle changes do you think would be in order for these patients?
Change your diet.
Okay. If they're taking NSAIDs, maybe they need to stop. And patients that are really dependent on them, maybe the patient has severe rheumatoid arthritis and they take them like every day, it's going to be an issue for them because once they come off the NSAIDs, they're going to be really uncomfortable and they're going to be hurting. So that needs to be addressed with them too. How can we manage their pain appropriately if they can't take the NSAIDs? What else can we do for them? Taking NSAIDs or antacids, smoking cessation, avoiding alcohol, trying to reduce stress and get out of nursing school as soon as possible, right? And then research has shown that there is no direct evidence that dietary restrictions make a big difference unless the food causes discomfort to each individual. So, like with a bland diet, that may be helpful at decreasing the symptoms, but what's going to be as helpful as anything is that patient avoiding things that irritates their stomach, whether it be hot, spicy foods or greasy foods or, whatever. So those are things that we need to think about with these patients as well. Other things that we haven't really talked about, I do want to touch on this, is complementary and alternative therapy. Hypnosis, guided imagery may be something that a person uses, yoga, meditation, all of those things. There's a couple of herbs that are supposed to be beneficial with promoting gastric health. Slippery elm is one of them. Marshmallow root is another one. And licorice, I believe, is also one that is thought to help heal inflamed tissue. Now, some of our minerals, as far as like zinc, vitamin C, the essential fatty acids, vitamin A and E, acidophilus, and glutamine are also minerals that help with the healing process. Okay, so now let's look a little bit at prevention. How can we prevent this ulcer condition from occurring in the first place? Well, if the patient is on NSAIDs, then we definitely want to make sure that they have proton pump inhibitors in place as well. So if you have a patient that is ordered some type of a steroid like Decadron or Solumetrol, make sure that they are on some type of a proton pump inhibitor as well. Is the patient older than 60, 50 to 60? It depends, but usually it depends on their comorbidities. I mean, some patients have a lot of comorbidities, so they're more fragile in their 50s. Rather than when some patients are not as fragile till they're in their 60s or later. Do they have a history of any type of peptic ulcer disease, any type of complications that go along with it, whether it would be bleeding, perforation? Are they taking anticoagulants? What other type of comorbidities may be going on with them? Now, for those who do not respond to the medication, surgery is an option. We don't do a whole lot of these surgeries anymore. A vagotomy is a procedure where they go in and clip the vagal nerve. And that's what helps with the secretion of the hydrochloric acid. So when we clip that nerve, that inhibits that production. We can do other procedures, subtotal gastrectomies, where part of the stomach is taken out. If you've got like a huge ulcer that's sitting in the fundus of the stomach, you may be able to have part of that stomach taken out, which is going to be very similar to a gastric resection, like weight loss surgery. So if it's enough of the stomach that is taken out, they may have problems with malabsorption and scar tissue forming. Pyloroplasties may be necessary if scar tissue has formed around that pyloric opening. We may have to go in there and do a pyloroplasty to open that stricture back up so that food can pass through it. But we don't see a whole lot of those anymore. The proton pump inhibitors has really helped us avoid a lot of those surgeries. Okay, so how are we going to manage these patients? We've already talked about the diet being controversial and avoiding the foods that may cause discomfort, because what causes discomfort in me may not cause discomfort in you. We want to encourage them to avoid alcohol, caffeine, and tobacco. Now, that can be a tough thing, because it may be somebody that will tell you right up front that they are not going to stop smoking, or they're not going to stop drinking alcohol. So in those situations, what we want to do is encourage them to at least cut back some. Or maybe it's somebody that drinks two 2-liter drinks a day with all that caffeine. So maybe we could encourage them to take in something that doesn't have caffeine in it. And we've already talked about the complementary alternative therapy as well. Now, what are some nursing concerns that we may have with these patients? Well, they're going to have pain. It may be acute, or they may experience chronic pain as well. If they have had a long-term problem with the ulcers, they are typically going to be malnourished. Their weight's going to be below the expected BMI for their height. They're not going to heal well because their nutrition is not what it needs to be. They're going to run a higher risk for bleeding, as we've talked about before. And this can be very anxiety provoking, because when you think about the people, okay, think about your smokers and you think about your people who drink, they sometimes have a little bit of anxiety anyway. So having this condition may intensify their anxiety and actually make it much worse for them. What type of knowledge deficits do they have? Do they know what's wrong with them? Do they know what signs and symptoms to notify the physician about? What types of foods bother them? How can they determine what types of foods bother them? And that can be quite a challenge for some patients. Now, in the past, we were talking about the food not having anything to do with the discomfort. In the past, research showed that eating 6 small meals a day may be helpful, but since then, it has shown that it's no longer a part of their treatment regimen. We don't even use that anymore because it has not proven to be beneficial. And it can actually increase the acid production. So we don't encourage that anymore. We don't encourage bedtime snacks. We like to encourage them to stay away from that. And the alcohol and the tobacco are going to increase the gastric production. So it is going to make it more likely for them to have more discomfort and a higher likelihood of developing the ulcers if they don't. But you and I both know that some people you're not going to change. So if we can just encourage them to limit their amount. How often do they need to see the doctor? If they've had a problem with GI bleeding in the past, what things do they need to look for? If when they're vomiting, is it bright red blood or is it coffee ground? What does it look like? We want to teach them all of this stuff too, because just because they've had the condition doesn't necessarily mean that they know everything there is to know about it. The other thing that we want to consider for these patients is the risk for fluid volume deficit, because if they're bleeding or they're malnourished, they're not eating because it hurts, then they're probably going to be dehydrated. So we need to be mindful about that as well, because we definitely want to keep their blood pressure up to perfuse their kidneys adequately, because the kidneys absolutely hate a low blood pressure. So we don't want that to happen due to our low fluid volume. Okay, so some of our goals of treatment, let's go back over those. We want to manage the pain. We want to eliminate the H. pylori if it's present through our triple therapy. We want to heal any ulcerations that may be present. And then we also want to prevent reoccurrence. So how are we going to evaluate if our therapy is effective?
We can ask the patient.
Okay.
There's been improvement in symptoms.
Okay, relief, yes, relief of pain. Are they doing better? No active peptic ulcer disease evident. No GI bleeding, maybe if that was a problem. Or if it does happen, they know what to do to manage it promptly. Are they adhering to their medication regimen and their lifestyle changes? So those are all things that we as healthcare providers need to incorporate in our education as well to the patients. So do y'all have any questions about any of that?
I have a quick question, and you might have went over this, but I think I just didn't hear it. So whenever I was looking over this, the H. pylori, so is that like a microorganism that causes the infection that we need to treat? Is that what it is?
Yes.
Okay, perfect.
Yes, it is. It's a little germ that that occurs because the neutrophils and some other chemicals in the stomach are activated. And what happens is it causes a necrosis of the epithelial cells. And then that bacteria produces a substance that damages the mucosa.
Okay, thank you so much.
Does that make sense?
Yes, ma'am.
Okay. All right. Any other questions?
Miss
All right. Yes.
As far as your test, like, can you get a little bit more detail, like on your layout? Like, we have a lot of content. So, is it nursing care, risk factors?
Yes. I will. What I will do is we will do a review on Friday. And I will post a blueprint as well. And what I try to focus on is care, nursing care for the patient. How can we safely take care of these patients?
Okay, thank you. Because right now I'm terrified.
It is a lot of information. It is a lot of information, but we're gonna work on that the last day of class. We're gonna try to really focus on what we've spent the most time on.
Thank you.
And what's the most important on that? Yes, ma'am. It is not contagious, and it's not necessarily. Yeah, and a lot of people have it, and we never even know it because they're never worked up for it, because it doesn't, unless they start having significant GI symptoms, they don't have an endoscopy done, so we never know that they have it. So, anything else?
Is it kind of like with the H. pylori, like almost like this in the same category as like having like a tapeworm or something like that? You know, because that affects your GI. You know, say if you eat something bad and then now you got a tapeworm, so now you know you're running to the bathroom every time you're eating. Is it like a bug like that, or is this almost like more just a more like a separate entity than something like a tapeworm?
Well, it's not a parasite.
Yeah, parasite. That's it, right. Okay.
It's not a parasite. It's a bacteria.
Okay, gotcha.
Yeah. So that's kind of the way that it works.
So you could be the healthiest eater and take good care of yourself and don't drink and don't smoke and still get an H. pylori ulcer, essentially.
You could potentially have one, and the only way that we would ever know it most likely is through you presenting with signs and symptoms of gastric problems and doing an endoscopy and doing some biopsies.
Okay, thank you.
So, now we do have the stool antigen test that can be done now, but I don't really know if anybody around here does that or not. I haven't heard or seen it done around here.
Yeah, I had that done, back home, a stool antigen test, I believe, where they they check for all that H. pylori, oviparasite, C. diff and everything. So I did have that, but I haven't heard of it too much anymore.
Yeah. All right. Well, y'all take about a 10-minute break and we'll come back and tackle pyloric stenosis. So I can keep you all on track. Can you hear me?
Yes.
Okay.
Yes.
Well, I think I stopped the recording from the last PowerPoint to this one, but if not, you probably heard this crazy lady talking to her dog. So just overlook it if you hear that on the recording, because he's in here with me.
Okay.
Okay, I'm going to share my screen with you again. And we're going to move on to pyloric stenosis. Okay. We are not going to go over the objectives because you can look at those. We don't need to spend time on that. Let's talk a little bit about the pathophysiology of pyloric stenosis. Basically, it's a very uncommon condition that happens in infants and just usually between birth and 6 months. Typically, after 6 months, you don't see it. And what happens is there's a blockage of food from entering the small intestines. Normally, we have the muscular valve, which is called the pylorus, between the stomach and the small intestines. And it holds food in the stomach until it's ready for the next stage of the digestive process. Well, in pyloric stenosis, the pylorus muscle thickens and it becomes very, very large. And then this blocks the food from reaching the small intestines. Let's talk a little bit about some of the risk factors. Males are more likely to develop this condition than females are, especially firstborn children. Pyloric stenosis is more common in whites of the Northern European ancestry, and it's less common in African Americans and Asians. Pyloric stenosis is more common in babies that are born prematurely than in full-term infants. Studies have shown that there has been a higher rate of this disorder among certain families. It usually develops in about 20% of the male descendants and 10% of the female descendants of mothers who had the condition. That's not something I expect you to know on the test. It's not going to help you take care of a patient, but it's just something that I thought was interesting for you to know. Smoking during pregnancy actually doubles the risk for pyloric stenosis to develop. Early use of antibiotics can also cause it. Babies who are given certain antibiotics in the first week of life, such as maybe they're given erythromycin for whooping cough or something to that effect, will increase their chances of developing pyloric stenosis. And also, babies who are born to moms who are or who did take antibiotics in late pregnancy also have an increased risk of developing pyloric stenosis. And some studies have suggested that bottle feeding rather than breastfeeding can increase the risk as well. Most of the people who participated in these studies used formula rather than breast milk. So it's not really clear whether the increased risk is related to the formula or if it's related to the mechanism of bottle feeding. So there's a couple of variables that might come into play there. So what are some signs and symptoms? Well, these babies are not going to grow properly. They're going to fail to gain weight. They're going to show signs of dehydration because they vomit very forcefully after they eat, and it's called projectile vomiting. They can vomit several feet away from them. It may be very mild at first, and then as the pylorus opening narrows, it may get more severe, and it may also contain a little bit of blood. They're going to have stomach irritation from so it's going to be kind of like a gastritis going on in their stomach as well. They're going to be hungry because every time they eat, they vomit, so they're not getting any nutrients, and we know how cranky a hungry baby can be. You may actually even be able to see stomach contractions. If the baby is very thin, you may be able to see the peristalsis in the upper part of their abdomen soon after they eat, maybe just right before they're getting ready to vomit. You can see the peristalsis increasing. And this is caused by the stomach muscle trying to force the food through that narrowed pylorus, and it can't do it. There may be changes in the bowel habits because food's not getting through, so the child may have some constipation. They may also have mucoid stools, which they're not going to have a lot of stools because the food is not getting through, but they may have that mucus from the inside of the colon that they may excrete. And they may be lethargic because they are dehydrated. They're not well nourished. So what are some diagnostic tests that we can look at for these babies? Well, we can certainly look at blood tests. We can look at to see if they're dehydrated or if they have any type of an electrolyte imbalance through blood tests. We can look at some X-rays to look at the images of the internal tissues, bones, and organs and other things on the X-ray film in that area. An ultrasound may also be very helpful, which, as you know, is the use of high-frequency sound waves and a computer that creates the images of look at the blood vessels, we can look at the tissues, we can look at the organs, and it helps us to look at the internal organs' function and assess the blood flow to various organs. So we can look at several things through an ultrasound. And then we may also require a barium swallow or an upper GI study. And this is an X-ray diagnostic test, of course, that examines the organs of the upper part of the digestive system that include the esophagus, the stomach, and the duodenum, which is the first section of the small intestines. And then a fluid, barium is a fluid. It's like a metallic type chalky liquid is used to coat the inside of these organs so that they'll show up on the x-ray. So we give that to the baby through a bottle, and then x-rays are taken to evaluate the digestive organs once this barium has been swallowed. And it looks to see how long it takes it to get from point A to point B as well, to see if there's any problems there. So what are some things that we can do to treat this problem? First of all, the patient's going to need some IV fluids because they have to be hydrated. So they're definitely going to have IV fluids. And then they may do a pyloriotomy, which is an opening of that tight pyloric muscle that will allow the food to pass through. Once it's repaired, the food should pass through very slowly. Most of the time, these kids start drinking small amounts of clear liquids in the first 24 hours, and that may be something like Pedialyte or something that's clear, a clear liquid. They may still vomit for a few days after the surgery due to the swelling at the surgical site of the pyloric muscle, but this swelling is going to go away in a few days and it is going to get better. So they may think in the beginning, oh no, this hasn't worked. Well, we just need to give it a little bit of time to get rid of some of that swelling. And most of the time, by the time the babies go home, they're usually taking their normal feedings, and they usually are able to go home in 2 or 3 days, depending on how well the child does. And the problem is unlikely to reoccur. So they should have no long-term effects from this condition once it's fixed. Do y'all have any questions about that? I just wanted to touch base with that just to make sure that you had seen it and was a little familiar with it in case you do see it again on boards. All right, no questions?
Nope.
Okay, then we're going to move on to the inflammatory bowel disease. So I'm going to stop sharing and pull that PowerPoint up and then resume sharing. Are y'all able to see chronic inflammatory bowel disease PowerPoint?
Yes.
Yes.
Okay, good. Okay, so I do want to point out the fact that there is a difference between the inflammatory bowel disease and the irritable bowel syndrome. Yes.
I just see your blackboard.
Okay. Can you see me now?
Yes.
Okay. All right. I do want to, first of all, there's this really neat very short video on Khan Academy that differentiates between chronic inflammatory bowel disease and irritable bowel syndrome. While you think in your mind that they're both very similar, they are, but they're different too. So if you have a chance, and do any of you use Khan Academy for anything?
Yeah, sometimes for certain topics, I'll watch something on there.
Yeah, I like it because they're very short and they're to the point. They don't tell me all this stuff that I don't need to know about what I'm wanting to research at the time. So that's why I like them. But they do have a really good one that differentiates between these two syndromes. And irritable bowel, I'm just going to say a little bit about it and then we're going to move on because I don't want to confuse you. But irritable bowel is non-inflammatory, and you typically find that in the lower part of the GI tract, and it's usually a functional problem, which means you have a problem with the mobility. For some reason, the muscles just contract a lot easier in that area, and that's all I'm going to say about that. Because I don't want to confuse it with what we're going to talk about next. But I just want you to know there is definitely a difference between them. Okay, so basically, chronic inflammatory bowel disease is kind of like an umbrella term for ulcerative colitis and Crohn's disease. So that's the two conditions that we're going to primarily focus on today. Ulcerative colitis is a widespread inflammation that can go anywhere in the colon, all through the colon to the rectum. It presents itself in remission and exacerbations. We don't know what the common cause is. It typically peaks between the years of 30 and 40, and then again between 55 and 65. Women are usually more affected in their younger years, and men are usually affected in the later years. For some reason, there is an increased blood flow to this area of inflammation, and we can have a problem with abscesses and the tissue thickening and obstructions occurring too. And we'll talk a little bit more about that in a minute. I put this picture on here so you could see the difference in the tissue between the inflamed and the normal bowel tissue. So you see how red and swollen the lower circle is with the inflamed tissue, and then how nice and smooth and pink the normal tissue is. So this kind of gives you an idea about what's going on in the gut. And it can be related to several things. It can be related to stress. It can be related to environmental factors. It can be related to maybe foods that we eat. So there's several things that it can be linked to. When we're talking to the patient and trying to get a history on them, we want to make sure that we include a history of their foods. What kind of foods do you eat? What kind of foods do you tolerate? What kind of foods do you not tolerate very well? What kind of elimination pattern do you have? Is it different after you eat these certain foods that you don't feel like you tolerate very well? Do you have an intolerance to milk or milk products or fried foods, spicy foods? Anything like that. Abdominal pain. What type of abdominal pain do you have? Where is your pain located? Does it become more intense after you eat? What type of, when we're talking about the elimination pattern, does the pattern seem to be related to any type of stress or any type of certain meals that you eat? Have they been outside the country? Have they been somewhere that they may have picked up some type of a parasite or a fungal infection that may be causing them to present with symptoms of ulcerative colitis? Have they been exposed to any antibiotics in the last 2 or 3 weeks, which could indicate possibly C. diff if they've had antibiotics? So we need to rule that out. What other do they have any other complications? Hemorrhaging, because you run a risk of perforation, abscess formation, pockets of infection can form in there and cause them to run low-grade fevers. And we look at all the other things, we can't find anything. And then whenever we do a CT scan there, we find a pocket of infection that has kind of walled itself off. Megacolon, we already talked a little bit about that on the previous PowerPoint, well, the first PowerPoint. Malabsorption. If they're having a lot of diarrhea, they're not going to be absorbing the nutrients from their food. And these patients with ulcerative colitis run a higher risk of developing colon cancer than patients with other inflammatory processes. So back to what we talked about before, some of the signs and symptoms, it can vary with acuteness of onset, and it can be very nonspecific because they can have a low-grade fever, they can have abdominal distension. Well, those can be related to a lot of things when you think about how many things those signs and symptoms could be related to. So we have to go through the process of elimination to figure out which might be the most likely cause for them having these signs and symptoms. If they're having a lot of diarrhea, they're going to have some skin integrity issues too. They're probably going to have some anal irritation and perineal irritation. If they're incontinent, that's going to even make it worse. What type of psychosocial aspects present themselves with these patients? We're looking at what type of support systems do they have available. They feel like they're tied to the toilet. They don't feel like they can go anywhere. They don't feel like they can do anything because they don't know when they're going to have to go to the bathroom. So they feel like they are just kind of tied to the toilet. Have they been maybe the primary breadwinner before, and now that this is developed, they can't take care of their family anymore? What type of support system do they have? Do they have family and friends that are able to help them, or do they live solely by themselves and maybe they don't have any children or a family? So all of those are things that we need to assess for whenever we are assessing these patients. Let's talk a little bit about the lab assessment. Hemoglobin and hematocrit is definitely something that we want to look at. It may be decreased because they may have some blood in their stool, and that's not uncommon for ulcerative colitis. Now, if they have a massive amount of blood and they're passing clots, that's area for concern. But it is not uncommon for them to have a small amount of blood in their stools. The white count may be elevated due to the inflammatory process that's going on. What's your CRP or C-reactive protein indicative of?
Inflammation.
Inflammation. So we've got inflammation going on in the colon, so it's going to be elevated too, right? And what about your SED rate?
Inflammation.
Same thing. You've got inflammation going on in that colon, so the SED rate may very well be elevated. Your electrolytes may be low because if they're having a lot of loose diarrhea stools, then they're losing a lot of sodium and potassium, aren't they? What about your albumin? Why do you think? I'm sorry?
Loss of proteins.
Yes, loss of protein in the stool. That's very common, especially when you're having 15 or 20 stools a day. And that's kind of what we're talking about. We're not talking about 3 or 4. And these patients usually have a lot of loose, frequent stools, and that's why they feel like they're tied to the toilet because they're afraid to go anywhere. They're afraid they will have an accident. So what are some of our diagnostic tools that we can use for assessing these patients? We may do an MRI to look at the cross sections of the GI tract to see what's going on. Colonoscopy is probably one of your best tools to use because they can actually get a true visualization and they can actually do biopsies if they need to. CT scan may also be helpful. A barium enema may be helpful early in your diagnosis because what is seen is an incomplete filling due to the ulcerations. You remember the pictures that I showed you on, I believe it was slide 3. You saw all those little holes. Well, what happens when you do a barium enema is that barium gets up and in those little holes, and it gets trapped in there. So that may be helpful early on. Some of the medications, these are very similar. Both medications are very similar, or classifications of medications are similar with Crohn's disease and with the ulcerative colitis. The aminosalicylates is probably one of your most common classifications of drugs that's used, and it has an anti-inflammatory effect on the intestinal wall. Typically, you're going to see it used with mild to moderate ulcerative colitis. Now, whenever these patients are taking this particular classification of meds, they also need to take folic acid with it, because the sulfa in the 5 ASAs decreases the absorption of folic acid in the body. So we definitely need to make sure that they take folic acid with it. And this therapy is kind of like your psych therapy. It doesn't happen overnight. It's going to take 2 to 4 weeks for you to be able to tell a difference in it. So they just, they have to kind of hang in there and be patient and compliant with the therapy over the 2 to 4 weeks until it really starts working. And this drug can also be helpful in maintaining remissions of ulcerative colitis. Zolpidem is also another medication that is used, and it is metabolized by the intestinal bacteria, and it actually increases the effectiveness of the aminosalicylates. So it can be used with those drugs as well, because it helps with that increasing the benefits of the drugs. Glucocorticosteroids is also another short-term drug therapy that may be used, because it does help decrease inflammation, and it also helps to suppress the immune system. And it can be mixed with the aminosalicylates as well. Now, you can either give it can be given orally. It can be given if they're having anal irritation from all the liquid stools that they've had, or if they have rectal irritation from the disease process itself. It can be given topically, or it can be given in an enema. So we have some alternatives there. Typically, it's going to be used with flare-ups, and as you know, we want to taper it when we get ready to stop it. We don't want to just stop it suddenly. We want to taper it off over the course of a few days. Antidiarrheal medications is another group of meds that can be used, but we have to use those with caution, because if we give them too much and then we cause them to not have any stools, then they can actually end up with a toxic megacolon and possibly an obstruction. So we want to be very careful about that. And we've already talked about the toxic megacolon and how life-threatening it can be. And it is a common complication of Crohn's disease and ulcerative colitis. Another group of medications that I wanted to mention to you is the biologics that are becoming much more popular, or immunomodulators. And basically what these are medications that alter the person's immune response. And these have to be used with steroids. They can't be used by themselves. And it's usually more effective with Crohn's disease. The main thing that we want to make sure that they know about is watching for any signs or symptoms of infection. Now, the biologics is another area that we are advancing in as well. And basically, with this particular group of medications, there's a selective targeting of inflammatory agents interfere with the inflammatory process, and that goes back to the cell level and everything. And we're not going to get into all of that because I don't feel like you need to know that to take care of the patient. But I just wanted you to be aware of the fact that, you know, we are coming along with the progression of the biologics and selectively targeting inflammatory responses. So hopefully that will prove to be promising for these patients over time as well. Surgical management. Let's talk a little bit about that. There's a couple of different things that we can do with these patients. They can have a laparoscopic colon resection, and whether the patient is a candidate for that or not all depends on what's going on with them. If they've had a perforation, they're not going to be a candidate for it because they're going to need to open them up to go in there and look around and clean everything up. There's another procedure that is becoming more popular, and it's called the NOTES procedure, natural orifice transluminal endoscopic surgery. And basically, with this particular approach, they either go in through the anus or the vaginal canal to approach the colon. So they are not making an incision on the abdomen, they're going in through another body orifice. These patients may come back with a colostomy too. It depends on the extent of the disease process when the physician does the surgery. And this ostomy may be reversible and it may not be reversible. It just depends on the amount of disease that they have in there and how much of their colon has to be resected. But the restorative proctocolectomy is your gold standard of care for these patients with the pouch anal anastomosis. Now, one thing that I do want to mention to you is when patients have these procedures, they may actually end up developing a fistula themselves. And that's, of course, as you know, an opening between two body orifices. A lot of times the fistula will present itself to the outside abdominal wall, and it just like continually secretes a small amount of mucus. So it may have to have a dressing on it, or if it's a lot of mucus, then you may end up having to pouch it. So that just depends on the patient. So how are we going to manage these patients post-operatively? Well, pain is going to be one of the major concerns because they're going to be hurting. They're going to be hurting because of the disease process. They're also going to be hurting because of the surgery that they've had. We're going to monitor them for any lower GI bleeding. If they have any lower GI bleeding, we need to report that and anticipate further lab tests and maybe more surgery or maybe a colonoscopy if they are a candidate for that. We want to make sure that they're hydrated very well. They may not be able to take in food for the first day or two post-operatively, so we need to make sure we keep their IV fluids going. Output, we want to make sure that they're putting out adequate urine output. Nutrition, that kind of goes back to the hydration. We want to get them back onto an eating plan as soon as possible. Monitor them for infections because they do run an infection, not necessarily related to the surgical site, but if they're not up and moving as much as they normally are, they also run a risk of pneumonia, and then we also run a risk of DVT. So we want to make sure that we have covered all of those areas. And if we have an infection at the surgical site and the person needs to go back to surgery, bowel prep is not going to be helpful. It's not going to be helpful one bit in that area because of the infection. Skin integrity, we've already talked a little bit about that. And if they end up with a colostomy, we need to monitor the skin around the stoma. And we'll talk more about that too in a couple of minutes. But we need to monitor the skin around the stoma and the stoma itself and what does it look like. So we have more work to do there as well in our teaching. So how are we going to plan and implement care for these patients? We want to provide them with the nutritional support that they need, and it may be that they need some type of nutritional counseling. They may need the dietitian to come and talk to them to try to pinpoint what foods may cause gas and may cause them to be uncomfortable, especially if they have a colostomy, because it's things like asparagus and cabbage and beans, foods that aren't well digested, like nuts and corn, are going to cause extra gas in that ostomy pouch. So it's going to have to be emptied more often, or the gas is going to have to be released from it more often, or you run a chance of the bag popping off. So we don't want that to happen. And just remember that every patient is very different. So we have to look at how they are presenting. Rest. Encourage frequent rest periods throughout the day and encourage them to avoid doing a lot of strenuous activity. They need to adhere to their weight restrictions for the first few weeks after surgery. Usually it's around 6 weeks that they require them to limit their weight before they can start picking up heavier things. Complementary alternative therapies may also be helpful with some patients. Vitamin C helps promote healing as well. And then, of course, your biofeedback, yoga, things of that nature. And then you're going to have other patients that put no confidence in those alternative therapies at all. So we may have to look elsewhere to find support for them. So let's talk a little bit about self-management education. So what are we going to teach these patients? Well, we need to teach them about the symptoms. How does their symptoms present? Because my symptoms may not present like your symptoms do. What type of remission and exacerbation periods are they having? Does it seem to be after a stressful event, or does it seem to be after certain foods have been taken in? What seems to be the triggers for them? How does their exacerbations present? Does it happen over the course of a day or two, or does it happen very suddenly? What can we do to control the abdominal pain and the cramping? And of course, if they have the ileostomy, are they able to manage that? Because they need to be able to take care of that. And you're going to have patients that are going to tell you right up front, I don't want anything to do with that. I do not want to take care of it. You can teach my wife or you can teach my daughter, but I am not taking care of that myself. So when we have a patient like that, we have to work with them. And a lot of times they will come around and eventually agree to learn to take care of it themselves, or at least know how to take care of it. Because when that pouch pops off at 2:00 in the morning, your home health nurse is not going to run out there and replace that pouch. So somebody needs to be available and knowledgeable to do that. Whenever an ileostomy is first placed, usually the stool is like kind of a dark green liquidy. And then as time goes on, it thickens up a little bit and becomes a little bit more pasty. And the small intestines actually begin to form and function. They begin to function as the colon did before, including the absorption of sodium and water. So We want to encourage them to take in plenty of sodium and water and to avoid any type of enteric-coated tablets or capsules because they're not going to be absorbed appropriately. And self-image is also a significant factor for a lot of these patients because, now they have the incision on their abdomen, and then they have the ostomy, which they did not have before, and they're having to make all of these lifestyle changes. So it can be quite discouraging for them. Any questions so far?
No.
Okay.
I don't think so.
Okay, so now let's talk a little bit about Crohn's disease. Okay. Crohn's disease is a chronic inflammation, and it typically affects the terminal ileum. It usually progresses very slowly, but it's unpredictable. If I have it, it may progress much more rapidly than it does in someone else. It is usually characterized by exacerbations and remissions. It typically peaks between 15 and 40 years. It can involve the entire colon, although it is most often seen in the terminal ileum. The cause is unknown. We don't really know why people develop it. We think that it is a combination of genetic, environmental, and immune factors, but we don't know for sure. And basically what happens is there's a thickening in the wall. I'll show you this next one. See that thickening in the wall, the intestinal wall? And you see those deep ulcerations. They almost look like a little cobblestone pattern to me. And the complications are very similar to the same ones that we talked about before. Cancer is very rare with this particular type of condition. It doesn't usually happen. If it does happen, the person has usually been diagnosed with Crohn's disease for like 15 or 20 years. They've had it for a long, long time. And this too is another condition that fistulas may form due to strictures and ulcerations that occur with the condition. And we've already talked about the fistulas and how it's an abnormal connection between two spaces. So, and most of these patients are going to require surgery at some point. It doesn't get better on its own. So what are we going to look for whenever we are assessing the patient? Well, we know that it's worsened by bacterial infections. So if they have some type of a GI bug or an infection in their GI system, or maybe they've been to the lake and they were swimming in the water and they got water in their mouth. Now they have Giardia, which is an infection that's caused by dirty lake water. That's going to make their Crohn's disease worse. They're going to have diarrhea. They may present with fever because of the fistulas and the abscesses, because if you go back and look at the previous picture, you see all of those little cracks and crevices in there. Those are prime sites for infection to set up. They may complain of abdominal distension. You may actually be able to feel masses through their abdomen if they're slender. If they're very thick, you may not be able to palpate any of masses. You may actually see the visible peristalsis too if they're fairly slender. They may complain of some perianal ulcerations because of all of the loose stools that they've had. They may have weight loss. What's their nutritional status like? They may have 5 to 6 loose stools or more a day. Steatorrhea is also common with these patients. Do you remember what that is?
Is that fat in the stool? Like the
uh-huh. Yes, it is. Uh-huh. Yes. And now let's go back to the perianal ulcerations. I want to make sure that you know we talked about the irritation, but they can also have fissures that form in this area, which is like little cracks in the anal opening, and then fistulas can develop there too. So that's why they may have some perianal issues going on. Their abdominal sounds may actually be absent if they're having an exacerbation. Their abdomen's usually going to be very rigid. It's going to be extremely tender, and they're going to have muscle guarding there as well. Blood in their stools is not as common as it was in the ulcerative colitis. So the pain depends on where the problem is, where the Crohn's disease is. If it's throughout the colon, their whole entire abdomen may hurt. But if it's in the lower part of the colon, it might just be the lower right quadrant. So it all depends. And they may have more pain before and after bowel movements as well. Hemorrhage is not as common with this particular type of condition. Intestinal obstruction is fairly common, and so is perforations. So what type of psychosocial aspects are we going to look at? It's very similar to the other condition that we looked at. We're going to look at lifestyle changes. What can they do to make it better? Because, we're all different, and different things affect different people. What type of coping skills do they have in place, or do we need to work on helping them develop better coping skills? What type of support system do they have in place? Do they have somebody that can take them to the doctor to get their medications, to go to the grocery store for them whenever they're not feeling well? Or do they live in an area that they have access to delivery services from these different things that they need? Depression is certainly a big factor because they don't feel like they're ever going to get better. They feel bad all the time because they have this inflammatory process going on. And it can make them very anxious too, because they start thinking about it. They're home all the time because they're afraid to go out. And then they get really anxious and start thinking about, well, what is going to happen to me? What's going to happen down the road? So those are all things that we have to think about whenever we are assessing these patients. So let's look at the lab work. As you can see, the lab work is very similar to the other disease process that we studied about. Hemoglobin and hematocrit may be low. Albumin may be low because of the decreased protein intake, or maybe the protein that's lost in the stool. Folic acid may be decreased. CRP and the SID rate may be elevated along with the white count, because we're looking at inflammatory process as well. Now, if we have a patient that has a lot of diarrhea going on, then we may find a low sodium. Their potassium and their chloride may also be low, or if they're having a problem with malabsorption related to the disease process. Okay, so as I said before, medications are very similar to the ones that's used for ulcerative colitis. Flagyl is probably the most common anti-infective drug that's used for infections and fistulas in this particular type of condition. And Cipro may also be used if the person should happen to be allergic to Flagyl. But we can use the anti-diarrheal medicines, the corticosteroids, the sulfonamides, antispasmodics, anti-infectives, and then of course we've already talked about the immune response modifiers that alter the immune system to target the source of inflammation. So let's talk about some interventions. They may need TPN. They may not be able to absorb nutrients, so they may have to have a central line placed for nutritional supplements with TPN. Now, TPN is a wonderful thing, but it brings along problems with it too, because with the high concentration of dextrose that TPN solutions have, the patient runs a very high risk of developing an infection, particularly at the site of the catheter, where the catheter is inserted, or the needle is inserted to give the TPN. So we have to watch them very closely for that. We also have to monitor their blood sugars early on as well. Now, hopefully, if the patient is stable and they have gone home on TPN, they're pretty stable on all of this stuff. But it's, as you know, this is a solution that is calculated daily as a result of their lab values. So the doctor comes in, he looks at the lab values, and then makes a determination of what he wants to put in the TPN for the next 24 hours. What should you do if your TPN runs out? It's got a high dextrose content. So what should you do? Any idea? Well, yeah, but now it's got, the thing you want to remember is that it's got a lot of dextrose in it. So if we stop that suddenly, what's that going to do to their blood pressure? Let's say that your bag runs out before the pharmacy gets the next bag up. What's that going to do to your blood sugar?
Drop it.
Mm-hmm. So what you can do in the meantime is hang a bag of D10, because you have to do something. You have to hang something. You cannot just let their TPN run out and like, oh, well, pharmacy's not going to be able to get that bag up here for a couple hours. It's like, no, that doesn't work. So you can hang D10 to supplement them until that next bag gets up there. And TPN is very expensive because it's such a process to make it. It has to be under sterile conditions, and it's a very long and tedious process. So typically the pharmacies will start in enough time that they have it mixed, and every patient's concentration of TPN is a little different depending on what their lab values show and what their needs are. Fistula management, we've already talked about that, how, a lot of times they're going to have surgical intervention for that anyway. They may actually have to have a wound vac, especially if they've had a perforation or they have a wound that won't heal. They may be left with open to second intention, which means from healing from the inside out. So the wound is going to be open, and they may have the wound vac applied. Now, one thing I do want to remind you with the wound vac, I don't know if you've had the opportunity to work with those very much or not, but always be very mindful about how many pieces of the sponge that you put into that wound. Because if you put 4 pieces in, I want to get 4 pieces out whenever I remove it and I have to replace it. Hopefully I won't have to, and it won't lose its suction. But in case it does, and I have to do that, I need to make sure that I know how many pieces you put in there. So you need to make sure that's documented somewhere on the dressing. Because what happens if a piece of the sponge is left behind?
You run risk of infection.
Mm-hmm. Absolutely. They run a very high risk of infection because it gets buried in that wound, and then all of that infection surrounds it and causes more infection. So then the person's going to have to go back to surgery for more debriding and more cleaning up, and it's just a mess. So always be sure you document that, and you document the type of drainage that is draining out through the wound vac. If it has any leaks, it's going to alarm and let you know. It will drive you nuts until you get it fixed. So you don't have to worry too much about that being a problem, because it will let you know. This next picture that I put on here is just to give you an idea of what a nice, healthy stoma looks like. We don't always get those in the hospital. A lot of what we get depends on what the surgeon has to work with. And you can see the little body over on the right-hand side. You can see the different places that the stomas can be depending on where the disease part of the colon is. And then if you look down at the picture on the bottom, you see how nice and red and pink that is and how moist it looks. That's the picture of a good stoma. Do they all look like that? No. Sometimes when they come back from surgery, particularly if there has been a problem with maybe they infarcted their bowel or they, for some reason, had a problem with the circulation, maybe part of their bowel died for whatever reason. The stoma may be kind of dusky and dark, and it may improve some over the next few days, and it may not because it's all that they had to work with. And you can see that they bring it out through the skin, and it reminds me of a little cauliflower. That's kind of the way I think of it. And then you can see that they suture it to the skin around the edges. And then you want your wafer to fit right around that outer portion on the skin, because we don't want the stool to get on the skin because it's acidic and it'll eat the skin up. But you want that wafer to fit right on that skin as close as possible to the stoma without being on the stoma. We don't want the wafer to be on the stoma because it can impede circulation and cause a bigger problem. Any questions? And most of the time, these patients, they'll come back with a pouch on, but usually it takes about 2 to 3 days for their ostomies to start working. They'll have some bloody drainage in the pouch, but they really won't have any stool for about 2 to 3 days because remember, it takes your intestines about 2 to 3 days to wake up from anesthesia. They wake up a lot slower than the rest of our body does. So it may take 2 or 3 days for you to start seeing any stool at all in the colostomy. And you always, of course, want to make sure you check on these patients often and make sure they don't have a lot of gas in their pouch or they haven't had a lot of stool in the pouch, because if they do, then there's a possibility that the weight of that stool can pull that pouch off. And then you have a bed full of stool that's all over your bed and it's all over your patient too. So just checking it every couple hours can hopefully avoid that. And we've already talked about some of the surgical interventions that would be appropriate for these. They could possibly be done laparoscopically depending on the extent of the disease. And they can remove as much of the colon as they need to. And then, of course, if they have any strictures along the way, they can certainly address those as well. That would hopefully be beneficial. Diagnostic tests are very similar. We can do colonoscopies. We can do CT scans to confirm the disease and the complications. And the barium enemas can be done, but we have to be very mindful with those that we don't cause a perforation, because if we cause a perforation, then all of that barium is going to be in their abdomen, and that's not good. What else? What other questions do you have for me? Do you have any questions? No questions?
No, ma'am.
All right. Okay. Well, I'm gonna stop there today because I feel like we've covered a lot of information today. And we will pick up on Monday with glomerulonephritis, colon and prostate cancer, and kidney stones. And let me know if you have any questions.
Dr. Bowie, I have a question about clinical.
Yes, ma'am.
If there's inclement weather, will the instructor just let us know, like, hey, we're not going to go today, or
Well, she may, or you use your own discretion. If you feel like it is unsafe for you, then don't go.
Okay, and just let them know.
Yeah, just make sure your instructor knows, because, I may have nothing in my area and you may have ice in your area. So it can't be, I can't make a decision for you because it's so different.
So if we do have that issue where we can't go, is there going to be a virtual assignment to make up?
Yes, we will work that out.
Okay. Thank
we
you.
We will work that out, because I definitely want you all to be safe. And, we don't know. We don't know what's going to happen. So far, we've only gotten rain this year. I said, I cannot believe that 40 states have snow and we have none.
Yeah, Ms. Bowie, I was getting ready to ask you the same question, because I'm out in Huntersville and I have the emergency department tomorrow night with Mr. Little, and that's an hour drive, at night. So
absolutely. You use your own discretion, because you know the area that you live in and how safe it is and what roads you have to travel on to get to your clinical site. But I don't want you to be unsafe, and I don't want you to be involved in an accident or anything.
Okay. Will we have to go to another clinical makeup, or would it be just a Swift River?
Probably at this point, I would probably just do another Swift River, because our time is so limited as far as clinical makeup and the sites that we have. It would probably be a Swift River assignment, most likely.
Okay,
it may be one of the. I might do one of those like I do on Thursdays, where we get together and talk about certain patients.
Okay.
I might do something like that.
Okay. I can email you in the morning just so, I can know.
Okay.
My time.
All right. That sounds good. Y'all be safe and have a good evening.
Thank you.
You're welcome.
Thank you.